Over to you, doctor.
Hi, good morning.
Good morning.
I would like to thank you for your kind invitation, and I'm very happy to share with you my presentation entitled Serious Iatrogenic Complication, Pulmonary Vein Stenosis After Ablation of Atrial Fibrillation. Well, some years ago, Tunisian et al. Wrote a paper in which they collect data on pulmonary vein stenosis after atrial fibrillation ablation, in which they said that this complication occurs in less than 1% of patients undergoing PV isolation, and that the incidence of severe symptoms is negligible. Following this publication, Capato published an editorial comment in which he said that these reassuring results indicate that clinically relevant pulmonary vein stenosis has evolved into a rare complication of AF-ablation. Well, I will try to convince you that is not true, because if we consider that in Europe, over 50,000 AF-ablation are performed every year, and that severe PVS rate ranges between 0.5% to 4%, that means between 250 and 2,000 cases a year, it is not a so rare complication. And I will convince you also that the incidence of severe symptoms is not negligible. Well, let me start with one of my cases. It is a 56-year-old male, very active, sportive. He underwent 3 ablations for atrial fibrillation and flutter, and in January 2025, he started having chest pain. Because of these symptoms, he underwent CT scan that showed what you see in the slide, lung opacities associated with enlarged mediastinal lymph nodes. So he underwent angio-CT that ruled out pulmonary embolism, but showed ectopic tissue around the left main bronchus infiltrating the left pulmonary veins. For suspected lung neoplasia, he underwent also thoracentesis for pleural effusion with a negative histology, PET-CT, which was negative as well, and brain and abdomen CT that excluded primary neoplasia. But they went on performing a bronchoscopy and a biopsy that were both negative for infective or neoplastic etiology. After multiple inconclusive invasive exam and worsening of symptoms, mainly dyspnea and hemoptysis, the patient came to our attention. We performed transthoracic echocardiogram that showed elevation of pulse Doppler force velocity in diastole of the left superior pulmonary vein. The CT scan, which was focused on contrast phase for pulmonary vein evaluation, showed stenosis of the left superior pulmonary vein and total occlusion of the left inferior pulmonary vein. So we went on and we performed an interventional procedure. You see here the stenosis of the superior pulmonary vein that was treated with bare metal peripheral stent. The left inferior pulmonary vein was totally occluded, as I said before, and this is the result after stenting. About halfway through the procedure, the patient began to experience severe cough accompanied by significant hemoptysis, which caused a rapid deterioration of respiratory parameters and required immediate intubation. What you see here are the fresh blood clots that were extracted from the patient bronchi. This allowed her to finish the procedure successfully. And this And this slide shows you the pre-discharge CTA with the 2 stents implanted in the superior and inferior left pulmonary veins. But what are the procedural factors of AF ablation that are associated with PV stenosis? As you probably know, there is a best approach for ablation and the wrong approach. The best approach includes a Carto system-guided high-density electroanatomic mapping that performs anterior lesions using a wide area circumferential ablation, what is named WACA. The wrong approach is performing the ablation at the ostium of the vein or even inside the pulmonary veins. So if we want to summarize which are the procedural factors, excessive number and duration of ablation, excessive energy, no WACA use, no eyes to guide the ablation, no 3D imaging before ablation, a low operator experience, the ablation within the pulmonary vein, the small pulmonary vein ostium, and multiple procedure of ablation. From the pathophysiological point of view, you see here in the slide what occurs in the veins. You see the large pulmonary vein that was surgically resected that shows virtually complete occlusion by fibromuscular proliferation. You see in B, small intrapulmonary vein with marked intimal proliferation, compromising the venous lumen, and even intrapulmonary artery with medial hypertrophy and eccentric intimal pressure, you can appreciate here, indicative of pulmonary arterial hypertension. This is a multifaceted disease with several clinical manifestations: fatigue, pneumonia, cough, dyspnea, hemoptysis, chest pain, pleural effusion. And these symptoms are those that cause a high rate of misdiagnosis. These patients are believed to have lung cancer, lung infection, lung infarction from pulmonary embolism, non-specific interstitial lung disease, idiopathic pleural effusion. All these wrong diagnoses lead to delay of appropriate care and unnecessary drug therapy and invasive diagnostic tests, as you have seen in my patients, or even surgical treatment. The most frightening symptom is hemoptysis. This is due to several histological changes in the pulmonary circulation. At the precapillary level, we have vascular remodeling typical of pulmonary hypertension with hypertrophy of the pulmonary artery media, resulting in reduced arborization of the pulmonary arterial tree. At the level of parenchyma, we have accumulation of intraparenchymal siderophages, septal thickening, mild interstitial fibrosis, pleural plaques, owing to organization of fibrinous exudates. Even the lymphatic are involved with enlarged hilar lymph nodes, lymphangectasis, and pleural effusion. At the level of the postcapillary circulation, we have arterialization of the pulmonary veins with intimal fibrosis and medial thickening, with venous varices mimicking AV malformations. We have remodeling of the bronchial arteries and bronchial veins with bronchovascular ectasia. You see in the slide a dilatation of a bronchial artery. And at the level of endobronchial mucosa, we have a friable mucosa, as you can see in the slide, that predisposes the patient to hemoptysis and recurrent airway infection. These are the chest CT of several patients. You see the patchy areas of consolidation, multiple nodules, ground-glass opacities, venous hemorrhages, interlobar septal and bronchial wall thickening. These are all signs of a lung disease, and this is the main reason of misdiagnosis in these poor patients. from the diagnostic point of view, echocardiography could be very helpful, but while transthoracic echocardiography lacks sufficient sensitivity in adults, TEE, transesophageal echocardiography, provides improved pulmonary vein visualization and functional assessment of stenosis, as you have seen in my patient. Ventilation perfusion mismatch can reveal, as you see in the slide in your right-hand side, the defect, the perfusion defect of the affected lung segment in case of severe hemodynamically relevant stenosis, and is an effective screening tool. However, a caveat, perfusion values are less likely to be conclusive in patients with bilateral pulmonary vein stenosis, as the measured percent flow to each segment is dependent on the flow to other segment. The gold standard diagnostic tests are CT angiography and MR angiography. The main advantage of CTA over MRA is a quicker acquisition of images, higher spatial resolution, and a lower cost. However, considering that MRA avoids radiation exposure, it should especially be considered for younger patients with long duration persistent AF who may need reintervention. What about treatment? There is no doubt that the best treatment is an interventional treatment. You see here a systematic review with a meta-analysis of 34 studies that clearly demonstrate that stenting is superior to plain or balloon angioplasty in terms of restenosis rate. 54% in this meta-analysis for balloon angioplasties versus 22.3% for stenting. The clinical and procedural risk factors associated with PV restenosis after percutaneous dilatation are, of course, balloon dilatation alone, as you have seen, and the balloon length, that means the length of the lesion. Multiple previous ablation procedures, and a high residual pulmonary vein to left atrial pressure gradient. A very important point is stent size. This is a study that definitely demonstrated that the risk of restenosis is inversely related to the size of the stent. Larger the stent, lower the stenosis rate. Smaller the stent, higher the restenosis rate. What about drug-eluting stent? Drug-eluting stent are very successful in the coronary arteries. They are not successful in this disease. It is a retrospective analysis that clearly demonstrated that DS are inferior to large diameter metal stent, and this is due to the fact that DS have sizes that don't go over 5 millimeters in diameter. Let me show my single center experience. 28 patients, 78 pulmonary vein stenosis. You see, these are quite young patients, average age 52, going from 31 to 74. The number of ablations, 63%, one ablation, 27% two procedure, 10% three ablations. But please look at the initial misdiagnosis of these patients. Almost 74% of these patients had a misdiagnosis of their disease, of their iatrogenic disease. And these are very sick patients. Look at the New York Heart Association class 3 and 4. Time from AF-ablation to PVS intervention, 16 months. And unfortunately, 13% of these patients had recurrence of atrial fibrillation. Symptoms at admission, you see in the pie how many symptoms this patient may have: dyspnea, cough, chest pain, pleural effusion, pneumonia, hemoptysis, fatigue, exertional dyspnea. So these are symptoms that may may make the physician think about a lung disease and not a iatrogenic problem. In my experience, you see that the left superior and inferior pulmonary vein were more frequently stenosed. I asked my electrophysiologist what they think about this higher percentage, and they think that the deeper movement of the ablation catheter into the left-sided pulmonary veins with respiration may be one cause, but also the smaller size of the left inferior pulmonary vein and the proximity of the left atrial appendage and the cumulative ridge to the left superior pulmonary vein may force the operator to ablate closer to the PV ostium. In 45% of this population, we had a chronic total pulmonary vein occlusion. You see here the stent length we used, the stent diameter, and we had a quite high procedural success, 98%. We had only one serious complication, a cardiac arrest secondary to respiratory failure requiring ECMO. The patient survived and was discharged. One of the more frequent complications during the procedure is hemoptysis. You have seen the case before, 24%, but this can be managed medically. One word regarding the treatment of pulmonary vein chronic total occlusion. This represents a unique diagnostic and interventional challenge. However, CTA sometimes suggests PV occlusion, which may not be present on selective angiography, so always perform an angiography if CTA shows an occlusion. CTA, however, is key for assessing technical feasibility and pre-planning of fluoroscopic angles to optimize ostial and distal vessel visualization. In fact, the favorable factors include the presence of a proximal entry beak to localize the PV ostium, short length of occlusion, presence of clear distal vessel targets. In my experience, the use of coronary CTO devices, such as dedicated wires for CTO, microcatheters, may be very helpful to increase the procedure success rate. These are the clinical outcome of our patient. You see a very important improvement, no symptoms at all in 29%, a great improvement in 32%, and also the New York Heart Association class improved very much at follow-up. However, even stents are not without problems. The problem is restenosis. You see 21% of patients had one restenosis, 5% had two restenosis. And these are examples of the follow-up. This is a case of stent patency. 6 months later, you see a pristine result of the stent compared to this case in which proliferation of endothelial cells occluded almost completely the stent lumen. What to do with restenosis of the stent? In stent restenosis, my strategy is predilation with a balloon, cutting balloon to extrude as much as possible the hyperplastic tissue, and then I go with a drug-coated balloon to try to reduce as much as possible the risk of proliferation. In conclusion, pulmonary vein stenosis is a rare but dreaded complication of AF-ablation, often resulting in severe and debilitating symptoms that can be confused for other pulmonary diseases, frequently leading to misdiagnosis and unnecessary drug therapy and invasive diagnostic tests. A heightened awareness of PVS signs and symptoms among all physicians caring for a patient with a previous AF-ablation procedure is imperative for early diagnosis and prompt management before development of PV chronic total occlusion and its sequelae. Any patient with a history of AF-ablation presenting with new onset cough, chest pain, fatigue, or hemoptysis should be considered to have PVS until proven otherwise. Mild and asymptomatic PVS may not need intervention. However, clinical and image surveillance every 3-6 months is advised as the disease can evolve over time. Early recognition of severe PVS earlier is a better approach, is essential because stenosis can progress rapidly to complete occlusion, leading to substantial reduction of successful recanalization rate and increased difficulty to deploy a large stent that I've shown you that is the best way to go, and therefore a higher restenosis risk. And finally, PV stenting offers lower restenosis rate compared with balloon angioplasty, as I show you, as a more than 50% restenosis rate within a year, and should be the first-line treatment strategy through a teamwork, imagers, interventional cardiologists, and electrophysiologists. Recurrent restenosis rate is significant even after stenting, hence patients should be monitored closely for development of symptoms, and routine imaging is advisable. In patients with in-stent restenosis, captive balloon angioplasty and drug-coated balloon may improve the intermediate result compared with standard angioplasty, but the final message is that preventing PVS in the first place is a much higher goal than determining the best way to treat this serious complication.